and patency. طيب. In the past, we used to check for gag reflex to see if the patient can protect their airway, but we found with recent studies that absence of gag reflex is not sensitive or specific as an indicator for need for an airway. So this is not an indication to intubate the patient anymore. In the past, if the patient had an absence of their gag reflex, that makes us to go and think about intubation, but this is not true anymore because it's not sensitive or specific. However, the presence of pooled material in the back of oropharynx is a good sign for poor airway protection. So when you examine the patient and you see that there is a lot of secretion in the back of their throat, and the secretion are pooled in the back of their throat, then in the oropharynx, then this is a good sign that they are not protecting their airway. So you have to start thinking about intubating that patient. And a very important distinction: spontaneous respiration and واحد قاعد يتنفس, that doesn't mean the airway is protected. So you can have normal spontaneous respiration and your airway is not protected. The example, البيشنت اللي عندهم low Glasgow coma scale, اللي هم coma patient, they are still breathing, but their airway is not protected. So spontaneous respiration doesn't equate to airway protection. Failure to ventilation or oxygenation is supplemental oxygen not effective. زي ARDS, زي الكوفيد patient الحين, COVID-19 for example, ARDS, pneumonia, respiratory fatigue or failure, زي الasthma, when a patient has bad respiratory distress and they're getting fatigued. Reasons like opioid overdose. An opioid overdose, you can reverse it with naloxone, but if they don't reverse, then you have to intubate them. Also, anticipated clinical course, and I mentioned this briefly. Deterioration of, for example, if you have a patient that are critically ill, for example, septic shock, and they're getting worse, then you anticipate that they're going to get sicker and sicker. So you intubate them to protect their airway and to help the patient out with their ventilator requirement. For example, another reason, like patients are exposed to a period of increased risk. For example, if you have a patient على سبيل المثال نقول في عرعر وتحتاج انك توصله للرياض for management in the ICU, and they're short of breath and they're in respiratory distress, they're going to travel for many hours. So sometimes you go because of long transport time من الحدود الشمالية للرياض, and you feel that you're worried that they're going to deteriorate on the airplane or on the car, whatever their mode of transportation to Riyadh, then you intubate them because they're going to be in a long transport time, and you're worried that they're going to deteriorate during the transport time. So sometimes we intubate patients for that reason. And again, sometimes you need to control the patient to do more testing on them. But if you control them and you give them medication, you're worried that they're going to deteriorate or they become more somnolent, and you're worried about their airway. And because of that, sometimes you intubate them. A good example for that, if you have a head injury patient and they're very combative, and you cannot control them, and you want to take them to the CT scan to rule out head bleed, but the problem is the patient is very combative and they won't lay still. So sometimes what we do is intubate them because we want to sedate the patient and we want to take control of the patient, to run some tests on them to rule out other devastating injuries. And because of that, sometimes we intubate those patients just to get them to the CT scan. Or if the patient has head bleed or a big hematoma around their neck, and you want to make sure that you want to protect the airway before they get before it gets worse. So you anticipate that this patient might deteriorate, so you want to protect their airway before they have to go that way. Okay. So let's say you have a patient in the emergency department and you want to evaluate their airway. As you remember, the way that we evaluate any patient in the emergency department, we run the ABCs, which is airway, breathing, circulation. This is the first thing that you need to do for any patient. So how do we evaluate airway? The first thing and the easiest thing, you can ask a patient question. You can ask them, what's your name? Okay. By asking this, the response, if if they respond correctly to this question, you will know for sure that they that their GCS is okay. So if you ask them their name and they responded correctly, the first thing that tells you about the neurological status of the patient, so their GCS is okay, and it tells you also if their speech is clear. It tells you that they are able to inhale and exhale in a manner required for speech, and it tells you that their airway is patent and they're able to control their airway. So if the patient respond well to what is your name, you know that the GCS is okay, and you know that they're controlling their airway. However, that answer only tells you about the patient status in one moment in time. So if the patient clinical status changes, you have to go back to airway assessment again, because that could change. The second thing that you need to do is to examine the mouth and oropharynx. And you're looking mainly for bleeding, swelling of the mouth and uvula, and also any abnormality that will interfere with passage of air. Okay. You need also to examine the mandible and the central face integrity to make sure that there is no fractures that in central face and mandible that might cause hematoma and bleeding, and that will jeopardize your airway. Also, you need to examine the anterior of neck, larynx, and trachea. Okay, so you want to palpate for subcutaneous air. You want to make sure that there is there's no hematoma or tumors. The reason why we want to palpate for spontaneous subcutaneous air, which will feel like crepitation underneath the skin, because that will, if you find a subcutaneous air in the anterior, around the airway, that makes you think about tracheal injury, pulmonary injury, esophageal rupture, and gas forming infections. Okay, you want to monitor the respiratory pattern. So if the meaning of what I mean with that is you want to see how the patient are breathing, and also if there is any added sound such as stridor. Stridor is a breathing noise that happens with inspiration, okay? And it means usually an upper airway obstruction. So you have to make sure that this patient doesn't have stridor. If they have stridor, that tells you that their airway is in jeopardy and it might close up. So that makes you think about protecting the patient's airway. And the last thing that you need to do is to assess the patient for possible difficult airway. Okay, and that puts you and make you think about getting your rescue devices, and you think about involving more experienced people such as anesthesia. And the way to assess the difficult airway by assessing four main things. So you want to assess for difficulty for bag valve mask ventilation. Also, you want to assess for difficulty for laryngoscopy and intubation, difficulty for extraglottic devices, and difficulty for cricothyrotomy. Okay, so those are the four main things that you have to assess. Each one of them, we have created mnemonics to help us memorize the steps to assess each one of these. So moans, is the mnemonic for difficult bag valve mask ventilation. Lemon is the mnemonic for difficult laryngoscopy and intubation. Rods is the mnemonic for difficult extraglottic devices. And short is the mnemonic for difficult cricothyrotomy. We'll talk about it one by one. So let's talk about difficult bag mask valve ventilation, which is MONS. So MONS, M for mask seal, O for obstruction or obesity, A for age, N for no teeth, and S for stiff lungs. Okay. So for the mask seal, the things that can make your mask seal difficult, things such as beard. So if the patient has facial hair, that makes the seal of the mask to the face more difficult. Airway obstruction, you have the way to assess that is to look inside the patient mouth and see if there's no tumors in there, hematoma. Look from the outside, make sure that there's no hematoma compressing on the airway. Obesity, if the patient is obese, they will have a shorter neck, and that will make it difficult to ventilate the patient, because obese patients have a lot of weight on their chest, and will make it difficult for us to get a chest rise and ventilate the patient. Age more than 55 is also associated with difficulty with bag valve mask ventilation. If the patient doesn't have teeth, it will make the mask seal difficult. The teeth help the mask seal on the face, and will make it less likely for the air to escape during bagging. So if they don't have teeth, that will make it very difficult to bag the patient. If the patient has denture, you want to keep the denture during the bag valve mask ventilation, but you need to remove it before intubation. Stiff lungs, such as the reason that the patient gets stiff lungs is such as ARDS or fibrosis. So if the patient has any of these conditions, it will make it difficult for you to ventilate them. So difficult laryngoscopy and intubation. The mnemonic is lemon. So L for look externally, E for evaluate the 332. We'll talk about it in a second. M is for the Mallampati score. O, again, obstruction or obesity, and N for neck mobility. So L for look externally, again, look at the neck, make sure that there is no hematoma or injuries, look at the face, make sure that there is no injuries or anything obstructing the airway in the mouth. For evaluate the 332, it helped the 332 rule help us evaluate for the mouth opening, and also help evaluate us to see if the airway is going to be anterior or not. And the way we do that, first of all, you want to have the patient open their mouth and try to stick 3 gloved fingers inside the mouth and see if it will fit. And if you can stick 3 gloved fingers in the patient mouth, it tells you that you have enough space to put the laryngoscope and the AT2. But if you have less than 3 fingers, then you will think that it will tell you that it will be difficult for you to fit the laryngoscope and the AT2, and you will have a smaller space, so it will be harder for you to manipulate during intubation. So as I said, again, your mouth must be open adequately to permit visualization past the tongue when both the blade and the AT tube are within the oral cavity. And again, the mandible must be sufficient to allow the tongue to be displaced fully into the submandibular space, and the glottis must be located sufficient distance caudate from the base of the tongue, so that can directly in line of sight that can be created to look from the mouth to the vocal cords and the tongue displaced inferiorly, which means that this it means that you want to have the by doing this maneuver or the 3-3-2 rule, you can check and make sure that the glottis is have enough distance from the mouth opening that will give you a space to have a good look at the vocal cords and to have a better view when during your intubation. Okay, so how can we do the 3-3-2 rule? The first steps is, again, you stick 3 gloved fingers in the mouth to check for the mouth opening. So 3 fingers between the upper and lower incisors. Then you check the distance between the mouth and the submandibular area or the mouth and the glottis by checking the distance or the length of the mandible by putting 3 fingers between from the mentum to the hyoid bone, and that will tell you again the length of the submandibular space or the mandibular space. I mean, so if you have 3 fingers, that means that you have an appropriate mandibular space. Then you check for the distance between the hyoid and the chin, which is the chin between the hyoid and the mandible. And here you want to be able to stick 2 fingers underneath the mandible. And if you're able to put 2 fingers, then you're good. If not, then you have to think about difficult airway. And usually what we do, if the 3-3-2 rule, we couldn't get the 3-3-2 rule, whether because of mouth opening or the length of the mandible, we have sometimes the safest way is to go for videolaryngoscopy, because the videolaryngoscopy doesn't need a lot of space and it doesn't need the visualization is better, because if the airway is a bit anterior or you have a smaller space, it will be difficult to get the line of sight correctly and be able to see the vocal cords during regular laryngoscopy. And usually we go to videolaryngoscopy during that situation. The Mallampati score, which is the M in lemon, is a score that we use to tell us if the patient has a difficult, if you will have a good visualization to predict the visualization of the vocal cord during intubation. And the way we get the Mallampati score is you ask the patient to sit up at 90 degrees and have the head in the sniffing position, which is slightly extension of the neck, and have the patient open their mouth and protrude the tongue without talking. Okay, so have them sit up, head in sniffing position, and open the mouth and protrude their tongue. And you want to have a look at their mouth or at their oropharynx. If you can see the base of tongue, and you can see the vallicula and the tonsils and tonsils pillar, okay, then this is class 1. So this is an easy airway, okay. If you cannot see the base, if you can see only part of the tonsillar pillar and tonsils and part of the vallicula, then this is going to be class 2, okay. If you cannot see the vallicula and you see only part of the tonsil pillar, but you cannot see the tonsils, this is class 3. And if you don't see anything, you just see the soft palate, this is class 4. Class 3 and class 4 are associated with higher intubation failure rate, which will be more than 10%. O from the lemon is obstruction and obesity. And you have to memorize the cardinal signs of upper airway obstruction. This is very important, which are muffled voice, difficult swallowing secretions, stridors, and sensation of dyspnea. If the patient has any of these, especially the muffled voice, difficulty swallowing secretion, and stridor, you need to think about upper airway obstruction, and you need to move fast to secure the airway. Otherwise, the patient will be in trouble. Stridor occurs when the airway circumference is less than 50% of normal. That's why we take stridor very seriously. So if the patient has stridor, that means their airway is about 4.5 millimeters, which is very, very small. So 4 centimeters and 4.5 centimeters, sorry. If the patient has stridor, you have to be very vigilant, and you want to secure the airway as soon as possible, because you want to, because if you don't act fast, it might lead to total obstruction. And also you have to be very careful of opiates and benzos, because if you administer opiates and benzos, their muscles surrounding the airway that keeping the airway open will relax, and the airway will collapse and obstruct. So be careful of opiates and benzos in patient that has stridor. And then prepare for double setup. Double setup means rapid sequence intubation and cricothyrotomy if the airway failed. So rapid sequence intubation, it means that we give paralytic and sedative and try to intubate the patient. And if we cannot intubate the patient, we'll move fast to surgical airway. But these two should be prepared at the same time. The N in lemon is neck mobility. So if the patient has C-spine immobilization for trauma, that will make it difficult for you to move the neck, and that will make the patient, will make the airway secure, will make intubating this patient very difficult. So then you have to think about to move through the difficult airway algorithm and think about other resources when you intubate this patient. We'll talk about difficult airway in a bit. Also, patient can have decreased neck mobility with rheumatoid arthritis or ankylosing spondylitis, which will affect the C-spines. And again, with patient that has issues with neck mobility, you probably will require video laryngoscopy. We'll move on to difficult extraglottic devices, which is the mnemonic is rods, are for restricted mouth opening. So the extraglottic devices such as King LT Airway or, sorry, I'll show you examples. The King LT Airway or the LMA, I'll show you examples later in the slides. They're large. Both of these are very large, and they need an adequate mouth opening. So if you have a restricted mouth opening, it'll be difficult to insert those devices into the mouth. So that will make it difficult. If you have any obstruction between the mouth and the airway, this is the airway here. If you have any obstruction between the oropharynx and the airway, it will be difficult for you to insert the device, because the device usually sits above the airway in the oropharynx. So usually it's set when just right before the vocal cords. So if you have any obstruction in this area, it will make it difficult for you to have the for the extraglottic devices to sit and secure that area. If you have distorted anatomy or disrupted anatomy, again, if you have any fractures in your mandible or mid-face, it will make it difficult for these devices to secure and seal the airway. So you need a patient that has no fractures and normal anatomy to use them. If you have stiff lungs or cervical spine, it will make it difficult again to as a back valve mask. Ventilation will make it difficult to ventilate those patients that has stiff lungs or obese patient that has a lot of weight on their chest. So stiff lungs, example for stiff lungs, we talked about this: severe asthma, pulmonary edema, ARDS, or patient that has decreased cervical movement. It'll make it difficult for you to insert the device in the first place, so it'll make it hard. H for hematoma, O for obesity, R for radiation, because radiation can create a lot of fibrosis in the neck. It will make it either the area bleeds a lot, or also make the anatomy a bit distorted, so you cannot access the airway easily. And if you have a tumor in front of the airway, it will be difficult to find the cricothyroid membrane and open it and get the airway inside it.
اقصد الجبن في جبن معين تحطينه ولا جبن بوق؟
الو لو ميوت لو سمحت. طيب بالنسبه زي ما تكلمنا احنا surgery or airway disrupted anatomic distortion ولا hollow devices make it difficult to access the airway, hematoma, infection, trauma, all of these can make it difficult to access the cricothyroid membrane. Obesity, it'll make it difficult because of access issues, short neck, large pannus, subcutaneous emphysema, careful palpation. You can with careful palpation, you can find the cricothyroid membrane and can access the membrane easily if you palpate correctly. But these are the reason why obesity can cause difficult cricothyrotomy. Radiation, as I said, it causes distortion of anatomy, scar tissues, and tumor, whether it's extrinsic or intrinsic, can cause difficulty to access the airway. Hello? طيب آسف. قبل ما نمشي للانتوبيشن تكنيكس، في أي أحد عنده أي أسئلة؟ عندكم أي أسئلة ولا تبغوني أمشي للتكنيكس؟
دكتور عندي سؤال أنا بس.
تفضل حبيبي.
هل إذا واحد جاني عنده أنافلاكتيك
أيوة.
Anaphylactic shock. Is it indicated for intubation?
إذا أحد عنده أنافيلاكسس شوك، شوف إذا أحد عنده أنافيلاكسس وأنت أعطيته إبنفرين، طيب، والإيروي صار عنده إديمة وصار عنده سترايدر وما didn't get better و start to get worse وصار hypoxic, yes, it's an indication for intubation. ليش؟ It's for airway protection. And you want to protect the airway, you anticipate that the patient will get worse, so you will intubate the patient to prevent the patient from having a total collapse of their airway.
شكرا لك يا دكتور على الإجابة. يعني إذا صار واحد عنده anaphylactic shock, probably with angioedema is indicated for intubation, for protection, yeah.
إذا عنده airway angioedema و that's not getting better بعد الابنفرين, yes, it's an indication for intubation. إذا صار عنده stridor و not getting with not improving with epinephrine, then will start to become hypoxic ولا patients start to become drowsy and not able to control their airway وصار عندهم secretion, then yes, you have to go ahead and intubate those patients. وفي الأخير الانتبيشن if you think about it, الانتبيشن عندك أنت كم شيء، عندك يا إما airway protection، طيب، يا إما مشكلة في الايرواي نفسها إنه الايرواي في issue you want to keep it open، طيب، أو مشكلة في اللنجز، يعني مشكلة في الأكسجينيشن والفنتيليشن، يعني هايبوكسيا وهايبركاربيا، طيب، هذول two main reasons. الريزن الثالث إنه أنت you anticipate and the patient will deteriorate. Then you want to intubate them, put them on mechanical ventilation to prevent them from getting worse. ممتاز.
شكرا لك يا دكتور، ما شاء الله، شكرا على التوضيح. الله يسعدك.
طيب السنيفنج بوزيشن أنا حوريكم صورة للسنيفنج بوزيشن. السنيفنج بوزيشن يكون فيه سلايد فليكشن على C1 جوينت واكستنشن في النك نفسها، يعني الهيد يصير الهيد الريليشن للبادي يكون قدام، الهيد يكون قدام والبادي يكون ورا. حوريكم صورة. في اي اسئله ثانيه ولا اكمل؟
دكتور كتب لك سؤال في الشاتنج، نبي نتدرب على التكنيك بس كلها اذا ممكن.
هذه كلموا فيها شو اسمه الكليه، لانه ما اعرف صراحه مع كوفيد وش الطريقه، يعني هو المفروض انكم تتدربون عليه بس كلها حسب ما اعرف، لكن هذه اشياء ممكن نتكلم فيها بعدين، بس نتكلم عن المحاضره الحين. في اي اسئله؟ طيب زين، خلونا نكمل. طيب الانتبيشن تكنيكس، how when you decide to intubate someone what do you need to do؟ طيب اول شيء حنرجع لهذه كلها. اول شيء you have to set up an IV access. Okay, put the patient on cardiac monitor, put them on oximetry or capnography إذا عندك. بعدين you have to plan your procedure. Okay, you have to plan your procedure with your nurses, with your respiratory therapist, residents. You have to have a clear plan of what you want to do. Okay, and what is your anticipated difficulty with this procedure. عشان كذا you have to go and assess for difficult airway, assess the patient, make sure that the patient doesn't have allergies to the medication, make sure that you have all of your backup equipment and all of that. Then you have to prepare your equipment. حنتكلم عن
سؤال بس إذا عن المقاطعة.
سام.
During intubation, if I encounter some difficulties inserting in, so there's an alternative for it. يعني في بديل عن الانتوبيشن إذا أنا حصل difficulties وأنا أسوي inserting in or
هنتكلم عنه.
أوكي شكرا.
طيب you want to prepare your equipment. Okay, you want to prepare the suction and all rescue devices، لأنه لو حنا ما قدرنا نسوي intubation إيش حنسوي؟ rescue devices حنتكلم عنها. طيب بعدين you want to pre-oxygenate your patient. Put the patient on 100% oxygen on non-rebreather mask. Okay, and you ask the patient to take multiple deep breaths. Okay, and the reason why you need to pre-oxygenate is to wash out. الحين حنا الأكسجين اللي حنا prepare the patient by we assess them for difficult airway اللي هي مون وليمون ورودز وشورت اللي تكلمنا عنها قبل شوي. هذيك airway assessment، هذه اللي تسويها أول شيء. بعدين we prepare them by putting them in sniffing position and pre-oxygenate them. بعدين we prepare the equipment. So what do we need? We need 100% oxygen at high flow, more than 10 liters per minute during mask ventilation, bag valve mask ventilation, or pre-oxygenation حتى. We need to prepare suction. we need to prepare the intubation tray, which has the laryngoscope and the handle. هذا اللارينجوسكوب، هذا الهاندل حق اللارينجوسكوب، وهذا اللارينجوسكوب. طيب we need to check the light. هذا اللايت سورس هنا. Okay, we need to check, we need to get the appropriate size airway اللي هو تقريبا عادة ناخذ حنا 7.5 to 8 في الميل و7 to 7.5 للفيميل. طيب فنشوف الاي تي توب، نختار السايز، بعدين وي تشيك البالون. هذه البالون we check انه البالون is okay by attaching a syringe and inflating air in it. We need to get an oropharyngeal airway valve mask ventilation. We need a stylet. stylet اللي هو زي الحديدة تدخل جوا الايرواي كذا. And I'll show you pictures of it to help stiffen the airway during intubation. We need a gel. We need a suction Yankower. And we need our backups. الباك اللي هو supraglottic device زي ال LMA أو King LT. We need a video laryngoscopy. We need a gum elastic bougie. And we need the cricothyrotomy اللي هو surgical airway kit. كل هذه لازم تكون جاهزة قبل ما you start البروسيجر حق الانتبيشن. So بالنسبة لللارينجوسكوبي، اللارينجوسكوبي عندنا two types. عندنا اللي هم الماكنتوش وعندنا الميلر. الماكنتوش الطريقة اللي أنا كنت أحفظها إنه الماكنتوش has a C والC is a curved. فعند الماكنتوش curved blade. لو لاحظتوا البليد كلها curved. طيب الميلرز فيها L's. اوكي فإتس a straight blade نفس شكل ال. طيب الميلر is a straight blade. هذه two types of blade that we have. طيب which has sizes, multiple sizes. الماكنتوش has 4, 3, 2, 1 and 0. نفس الشيء الميلر 4, 3, 2, 1 and 0. طيب عادة في الادلت الفيميلز والميلز نستخدم لهم 3. الميلز بعض الميلز اللي يجيك طولهم طويل حول فوق المتر 80 تقريبا متر 90 نستخدم لهم 4. الميلرز عادة نستخدم 2 أو 3. طيب هذا بالنسبة للأدلت. اللارينجوسكوب has a handle. هذا الهاندل في بطاريات هنا. طيب وهذا الهاندل اللي تمسكه وفي الهوك بيس أنت تشبك هذه اللي هو البليد تشبكها للهاندل. البليد has a light source. اللمبة تطلع من هنا هذا اللايت سورس وبس هذه. Okay so this is our laryngoscope. This is اللي هو الكلاسيك laryngoscope. طيب الاورال airway والنيزل airway هذول adjuncts نسميهم تساعدنا during الماسك ventilation. ليش؟ during لما تعطي patient sedative وباراليتيك المسلز اللي هنا هذه كلها ترتخي. الايروي مسلز هذه كلها ترتخي. فاللي يصير انه يصير الايروي get collapsed لانه يصير الايروي ما ينفتح. ف what we do is يا اما نحط النيزل airway اللي يدخل من النوز يفتح لنا زي المسار all the way للايروي هنا، او الاورال airway اللي يسحب لك التنق على قدام. طيب and open up the airway and will help you with the bag valve mask ventilation. Okay, so we use these as an adjunct device to help us with bag valve mask ventilation. it's not an airway, it's not an يعني اللي هي ال airway that we use زي ال ET tube ولا ال LMA. هذه بس إنها adjunct to open up ال airway to help us with bag valve mask ventilation. ال ET tube الendotracheal tube. طيب زي ما قلنا فيه بالون. البالون هذا لما يدخل ال ET tube يكون الفوكال كوردز تقريبا هنا. هذه لو تخيلنا هذه الفوكال كوردز. اوكي، يدخل بعد الفوكال كوردز يصير في بالون. البالون هنا ندخل البالون بعد الفوكال كوردز يصير تخيل الماوث هنا، الماوث تكون. طيب وهذا الفوكال كوردز. بعد ما تعدي الفوكال كوردز تعدي البالون بعد الفوكال كوردز وتوقف، بعدين تنفخ البالون فيقفل لك الايروي. هذا التريكه تصير زي كذا زين، فيقفل لك التريكه تماما، فاتبروتكت التريكيا. طيب من السكريشنز اللي تجي من الاسوفاجس من الماوث، فلانها تقفل التريكيا تماما، عشان كذا نقول اير واي بروتكشن. زين. فانت قبل انتبيشن، قبل ما يو اندوس ذا بيشنت، يو هاف تو تشيك البالون، تتاكد ان البالون لما تنفخها تقعد مفخوخه ما تنسم. طيب الشيء الثاني you have to have a stylet with you. stylet تحطه داخل ال AT tube to help stiffen up the AT tube and make the tube more stiff, فبالتالي will make it easier to guide it through the airway. الشيء الثالث في عندنا اللي هو السكشن apparatus، اللي هو هذا اسمه يانكاور. اليانكاور هذا اللي هو السكشن apparatus اللي هو stiff suction. we connect it to the suction في الجدار. okay, and you have to connect it and make it ready to make sure that when the patient, if the patient vomits, you can suction the vomit or any secretion. So you have to have that prepared and ready. Okay, and this is how your intubation tray should be prepared. So هذا الباك valve mask ventilation device اللي هو هذا الباك valve mask اليانكاور. عندك اللي هو اللارينجوسكوب، وعندك ال LMA اللي هو supraglottic device. ET tube تكون عندك 2 ET tube جاهزة. مو كلها لازم تكون طالعة برا الغلاف، بس واحدة تكون جاهزة طالع والثانية تكون باك اب. لوب و10 cc سرنج، لأن ال 10 cc سرنج تشبكها في ال ET tube وتنفخ البالونة. طيب oral airway nasal airway. اوكي، وبكذا تكون انت prepared. طبعا هذا اللي هنا هذا الجم elastic بوجي هنتكلم عنه. كذا شكل التري حقتك تكون. عندك الماكنتوش لارينجوسكوب او الميلر. الموست كومنلي يوز الماكنتوش اللي تستخدمه في كل الطوارئ واكثر الناس يستخدمونها في الاي ار، في الانستيزيا، في الاي سي يو، هو الماكنتوش بليد. كذا الاي تكون تكون جاهزه، ستايلت داخله. البالون تشيك عليها مشبوكه 10 سي سي سرنج فيها 10 سي سي اير. هذا ال LMA اللي هو السوبراجلوتيك ديفايس، وهذا الاورال ايروي. طيب after you prepare everything وكل شيء صار عندك جاهز، you go ahead and induce the patient. احنا وش قلنا؟ قلنا الاندكشن اللي هو giving a sedative. تعطي sedation للبيشنت اساس البيشنت lose consciousness، وبعدين تعطيه الباراليتيك، لان ما تبغى تعطي الباراليتيك والبيشنت صاحي، لان البيشنت يحس يصير فجأة مشلول، ما يقدر يتحكم، ما يقدر يتنفس، لكنه واعي. عشان كذا لازم نعطي السيداتيف قبل الباراليتيك. الموست common sedative being used اللي هو الاتاميديت، بروبوفول، كيتامين. طيب ما ابغاكم تعرفون الدوزز. طيب ما هي مهمة الدوزز بالنسبة لكم في الليفل هذا. اللي ابغاكم تعرفونه انه ليش كل واحد، ايش ميزة كل واحد عن الثاني. طيب كلهم تقريبا، البروبوفول هو اسرع واحد، بس كلهم يبدون في اقل من دقيقة. طيب وكلهم تقريبا يجلسون لكم ثلث ساعة. فنفس البروبرتيز تقريبا. الفرق بينهم انه الاتاميديت الموست امبورتنت ثينج واللي ابغاكم تتذكرونه انه الاتاميديت نيوترال للبلد بريشر، ما ياثر على البلد بريشر ابدا. طيب حتى الكتامين ميزته انه يرفع البلد بريشر، يعني لو عندك واحد هايبوتنسيف الكتامين حيكون احسن من الاتاميديت. ايش مشكله البروبوفول؟ مشكله البروبوفول انه decrease البلد بريشر. طيب الشيء الثاني الاتاميديت، طيب الميزه الوحيده انه عنده نيوترال بلاد بريشر، ما ياثر على يسمونه احنا نقول انه كاردياك ستيبل او كارديوفاسكولار ستيبل. البروبوفول المزايا الثانيه اللي عند البروبوفول، عيبه وش عيب البروبوفول؟ قلنا انه ياثر على البلاد بريشر. ميزه البروبوفول انه انتي كونفولسنت، انتي سيجر، فاحيانا لما يصير عندنا a reason to intubate is to protect the airway for someone who has status epilepticus نستخدم البروبوفول، ما نستخدم الاتاميديت. ليش؟ لانه انتي كونفولسنت. طيب والكتامين is a bronchodilator. طيب فبيشن لو جانا بيشن عنده asthma severe asthma that requires intubation نستخدم الكتامين لانه it's a bronchodilator، ما نستخدم البروبوفول والاتاميديت. طيب but that's mainly. بس اللي ابغاكم تتذكرونه most important thing انه propofol decrease blood pressure، والباقيات والكتامين يرفع البلد بريشر، والاتاميديت ما ياثر على البلد بريشر. بعد ما نعطي السيديشن
نسويها الكيتو بروبوفول.
خلها الاسئله في الاخير عشان ما نتلخبط. طيب اي سؤال اكتبوه على جنب وبعدين نساله في الاخير. طيب بالنسبه للباراليتيك، طيب بعد ما نعطي اندكشن نعطي نخلي البيشنت بارالايزد، فنعطي باراليتيك اجين. ما ابغاكم تعرفون الدوزز، لكن الشيء المهم ان الاونست ساكسينال كولين اللي نسميه ساكس باد هو اسرع واحد فيهم ولاست ذا شورتست، يقعد من 5 ل 9 دقائق بعدين يروح الافكت حقه. الباقيات الروكرونيوم من 1 إلى 3 دقائق ويقعد تقريبا إلى 45 دقيقة. البيكرونيوم ما نستخدمه في الاندكشن، عادة نستخدمه في الاي سي يو عشان نخلي البيشنت بارالايزد، بس انه عادة التو ايجنتس اللي نستخدمها في الامرجنسي ديبارتمنت اتليست اللي هو ساكسينال كولين والروكرونيوم. طيب لكن مش مشكلة الساكسينال كولين، مشكلة الساكسينال كولين عنده كونترا انديكيشنز كثيرة. يعني إذا patient عنده had burned more than 5 days ago، أو عنده denervation injury، صار عنده neuro injury أكثر من 5 أيام، أو significant crush injury أكثر من 5 أيام، أو severe infection أكثر من 5 أيام، أو pre-existing myopathy، يعني واحد عنده myasthenia gravis أو عنده ALS، أي neuromuscular disease. طيب can cause fatal hyperkalemia. يعني لما تعطي البيشنت الساكسينال كولين البوتاسيوم يطلع حقه ال 8 9 ممكن يقتل البيشنت. فعشان كذا ساكسينال كولين احنا we have to be very careful when we use it. When we use الساكسينال كولين you want to make sure انه ما عنده اي شيء من الكونترا انديكيشنز، هذه كلها absolute contraindication to use الساكسينال كولين. It can cause bradycardia, it can cause increase in intracranial pressure, malignant hyperthermia. هو الميديكيشن الكلاسيك ميديكيشن اللي cause malignant hyperthermia. prolonged can cause masseter spasm اللي هو mouth spasm. فعشان كذا الناس start to move away from the succinylcholine and start using rocuronium أكثر. لكن مشكلة الروكرونيوم مو موجود في كل مكان، السكس متواجد في كل مكان. فالمهم بالنسبة لكم أنكم تعرفون أنه succinylcholine can cause hyperkalemia في السيتويشن هذه، فmake sure أنه you understand that. طيب pre-oxygenation تكلمنا عنه 3 minutes of tidal volume. tidal volume يعني deep breath مدة 3 دقائق at 5 ml per kilogram 100% oxygen. أو إذا تبغى تسوي rapid pre-oxygenation وهذا اللي نسويه في الإي آر، نخليه ياخذ 8 deep breaths within 60 seconds at 10 liter per minute. طيب sniffing position، هذا sniffing position إنه بهالطريقة هذه flexion of the neck، flexion of the neck، so النك تكون متقدمة عن البادي، واكستنشن of the atlanto-occipital joint. هذا الاتلانتو-occipital joint هنا. اوكي extension هنا. شوف كيف هذا الراس يكون راجع على ورا والنك على قدام. طيب هذا sniffing position. And the reason ان نسوي sniffing position، شوف الفرق، هذا النورمال position. طيب هذا supine position. انت تكون واقف هنا، هذا اللي هو الاكسس اوف ماوث، وهذا الاكسس اوف الفارنكس اللي هو سوري هذا الاكسس اوف لارنكس. فانت لما الفوكل النظر حقك او الاكسس حق النظر حقك جاي زي كذا، وعشان تشوف الاير واي ما حتقدر تشوف لانه مغطي عليك. فالطريقه اللي الافضل انك تحطها في sniffing position. So if you put the patient in the sniffing position، طيب you align اللي هو الاكسس اوف سايت حق مع laryngeal axis. you align all of these axes ويصير عندك airway او you can visualize your the patient's vocal cord. So it's much easier to when you put the patient in the sniffing position, it will make all these axes line up ويخليك تقدر تشوف airway much easier. فعشان كذا احنا نحطهم في sniffing position. طيب the other thing what we could do is we can if the patient is obese, to achieve a better positioning we do the ramp position. والramp position نحط multiple towels ولا multiple blankets بحيث ان نرفع الهيد طيب عن البادي، لأن البادي is huge in obese patients. So you need to lift the upper part of the body and the head and align the ear to the sternal notch. Okay, and this is the way that you know that you achieved sniffing position. The way that you know that you achieved sniffing position is if you have your if the ear aligned with the sternal notch. When the ear aligned with the sternal notch, you know that you achieved a good sniffing position. So as you can see here, ear to sternal notch, they're all aligned. طيب, والhead is elevated, and this is the way you position the obese patients. طيب, after you position the patient and you position the patient before you give the medication, the induction medications. So the first step is prepare your equipment, prepare the patient, pre-oxygenate, position the patient, بعدين give the medication, بعدين you will start intubating the patient. The way that we intubate the patient, أول شيء we visualize the airway. How do we visualize the airway? أول شيء you open the mouth with the scissoring maneuver, انك تحط your index finger على your thumb على lower incisors والindex على upper incisor, and you open it in a scissoring fashion. Then you insert the laryngoscope to the right side of the mouth, and you sweep the tongue to the left. Okay, and then you advance the blade until it lies in the vallecula. I will بوريكم الvallecula, and I will show you a video in a second. And then pull it forward and upward using a steady pressure without rotating the wrist. Avoid the blade touching the incisors so it doesn't break the upper teeth. Okay. If you have difficulty seeing the vocal cord, then you will have to apply pressure to the airway. So again, you insert it to the right, you insert اللي هو laryngoscope to the right, and you sweep to the left, moving the tongue out of the airway, out of the way. Then you can see اللي هو vocal cord. This is the vallecula. So you insert laryngoscope, you advance it until you get it into the vallecula, which the vallecula is the space between the tongue والglottis. Okay, and this is the view that you're looking for. This is these are the vocal cords. So you want to see this view. Okay, this is grade 1 view, we call it. If you once you see the vocal cords, then you insert the ET tube between them. Okay. Those are the grades of the view. So grade 1, you can see everything, can see the arytenoid and the vocal cord. Grade 2, you can see only the arytenoid part of the vocal cord, but not all of them. Grade 3, you only see the glottis, but you don't see anything else. Grade 4, you don't see anything. So grade 1 associated with 99% success in intubation. Grade 1, grade 2 has 1% failure rate. Grade 3 and grade 4 are much more difficult. Okay. Then after you, as I said, after you see the vocal cords, you insert the ET tube until the balloon passes through the vocal cord. Once the balloon passes through the vocal cord, about 2 to 3 centimeters after the vocal cord, you inflate it, and then you secure it in place, and make sure that you inflate it with 10 ml air, and then listen. Make sure that you listen that there's no leak when you blow air inside the ET tube, and make sure. Then after that, you want to make sure that the placement is correct. So you listen. So you listen in 4 places or 5 places. Sorry. So you listen upper chest, lower chest, and then in the epigastric area. Okay. Also can connect it to color capnography or end-tidal CO2 to check for CO2. If there's no CO2 coming out, then that means that the ET tube is in the stomach, not in the lungs. If it's in the lungs, it will turn the color capnography into yellow from purple. Or if you have an end-tidal CO2 monitor, it will show you CO2 coming out on the monitor. Then you do a chest X-ray to make sure that you have a correct placement. The failed airway means that you have failure to maintain or acceptable oxygen saturation during or after a failure to maintain an acceptable oxygen saturation during or after one or more failed laryngoscopy attempt. Okay, or it's 3 failed attempts at orotracheal intubation by an experienced intubator, even when the oxygen saturation can be maintained. So a failed airway, either desaturation while you're trying to intubate after 1 or more attempts, or 3 attempts with or without desaturation. So what are the risks? If you failed to intubate a patient, then you start rescue airway procedures. So the rescue airway devices, the first device is gum elastic bougie. So it's a semi-rigid stylet, very long stylet that you can use blindly. So you put it inside the patient airway blindly, and usually because of the weight, the curvature, it guide itself into the airway, and you can feel the tracheal rings. If you feel the tracheal rings after inserting, then this is most likely, that means that the bougie most likely is inside the airway. And you can put the airway or the ET tube above it, and it will guide the ET tube inside the airway. I've attached a YouTube video for you guys after the lectures. You can have a look at it to see how it works. Okay, the second rescue device is LMA, low laryngeal mask, or King LT. Both of these are supraglottic device. Why we are saying supraglottic device? Because it stays above the glottis, okay? And usually the LMA, the tip of the LMA usually obscure or obstruct the esophagus, and the mid of the LMA, where you have the ventilator slits, lay over the trachea, and that's the way the air comes through through this and goes into the trachea, get guided through the trachea. And you can, with the LMA and the King LT devices, we can ventilate the patient and intubate the patient blindly. Sorry, not to intubate the patient, but we can use these devices blindly. So the LMA, you can just shove it in there and you can start bagging the patient, and usually the oxygen will reach the lungs without any issues. The same thing with the King LT tube, or combi tube is the other name for it. You place it blindly, and the tip of the tube will end up in the esophagus usually, and you can ventilate through openings at the side of the tube in here. Again, I've attached another video for you guys to watch later on. The last thing is surgical airway or cricothyrotomy, and the cricothyrotomy usually is the last rescue maneuver if supraglottic devices failed and intubation failed, videolaryngoscopy failed, which I attached a video here for it. Then we go to cricothyrotomy. The videolaryngoscopy, we have multiple devices. The most common one that you guys probably have seen, either the CMAC device or the GlideScope. Those are video devices that you can use to visualize the airway, and by using them, you can intubate the patient with the video, because it will give us an increased visualization and will make the intubation easier. We use the videolaryngoscopy in restricted oral opening patients or cervical spine mobility or any difficult airway. Cricothyrotomy, we use it, it's a surgical maneuver where we can open, we do an incision at the cricothyroid membrane, and we put a tube inside the cricothyroid membrane, then into the trachea, and that's a surgical airway, and it's the last step in failed airway. The last thing I want to tell you, talk about just for a little bit, is non-invasive positive pressure ventilation, or BiPAP. BiPAP is have helped us avoid a lot of intubation in the emergency department, especially in two-patient population. So it's an alternative to endotracheal intubation in patients with ventilatory failure due to chronic obstructive pulmonary disease, COPD, and cardiogenic pulmonary edema or acute heart failure. So in these patients, pulmonary edema and COPD, BiPAP actually is better than intubation, and you have to try them before intubation. But the patient needs to be cooperative without cardiac ischemia, hypotension, or dysrhythmia. So the difference, there's two modes for it. There's CPAP. So the name of the modality is non-invasive positive pressure ventilation, NIPPV, and they have two modes: CPAP, continuous positive airway pressure, or BiPAP. CPAP provide continuous pressure, and we use it mostly in patients that has at home, for patients that has obstructive sleep apnea, and also we can use it for cardiogenic pulmonary edema. BiPAP is bi-level, so it helps with CO2 washout, and we use it for COPD exacerbation patient or also pulmonary edema. The contraindication, as we said, cardiac arrest or respiratory arrest, inability to protect airway, poor cough, excessive inability to clear secretion, decreased consciousness or coma, upper airway obstruction, untreated pneumothorax, marked hemodynamic instability, shock, ventricular dysrhythmia, severe acute myocardial infarction, GI bleed, maxillofacial trauma, or intractable vomiting. The advantages: you need no sedation, non-invasive, patient able to maintain verbalization, early improvement in hypoxia, acidosis, or hypercapnia, shorter hospital stay, decreased rate of intubation, decreased mortality. It did decrease mortality in a lot of patients. Now, some of the patients, especially COPD exacerbation or cardiogenic pulmonary edema, sometimes they get discharged from the emergency department because of these devices. Their adverse effect is respiratory anxiety, agitation. Patient that has claustrophobia, you cannot use it on them. It can cause abdominal inner compartment syndrome. A patient with abdominal compartment syndrome, pulmonary barotrauma leading to pneumothorax, respiratory alkalosis, or air trapping. And that's it for now. The last thing I want to show you is just quickly an intubation.
Step is a jaw thrust.
Can someone tell me if you guys hear the sound?
Chin and place your fingers firmly behind the angle of the mandible and lift.
تسمعون صوت الفيديو ولا لا؟ ولا بس صوتي؟
Successful ventilation is confirmed in order to pass the tube through them into the trachea. This requires a laryngoscope. We will teach the traditional direct laryngoscopy, but for filming purposes, we use a video laryngoscope that has the same shape.
طيب الآن بس أبغى أوريكم how to intubate a patient. زي ما أنتم شايفين الحين this maneuver called jaw thrust. لما تحط fingers behind the jaw and move it up. The patient is in the sniffing position as you can see here. زي ما تشوفون أن flexion at the neck و extension at the atlantoaxial joint. طيب ear at the sternal notch, at the level of the sternal notch, and now they are bagging the patient. طبعا هذه في OR. The difference إنه في ER يكون عندنا bag valve mask instead of this device. طيب now they're inducing the patient, paralyzing the patient. I mean, sorry, they already induced the patient. طيب watch the patient hand, the intubator hand. So this is the scissoring maneuver that I told you about. So they're opening the mouth, okay, inserting the ET tube, من اليمين from the right side, and then moving the tongue to the left. And this is your airway. You can see here the glottis, the blade is in the vallecula, and you can see the arytenoid and the vocal cords. وزي ما تشوفون الانتبيتر واقف وبعيد لأنه يبغى this is the best line of sight. You don't want to get closer to the mouth. شوفوا على اليسار. بعدين once you insert the blade, you want to move it up and to the left. هذا الايروي قدامك. Then you insert the ET tube. You insert the balloon past the vocal cord for about 2 centimeters. بعدين توقف خلاص. Inflate the balloon and the patient is intubated. طبعا هم عندهم Untitled CO2. هذا الأصفر هو Untitled CO2. هذا عادة مو موجود في الطوارئ. Some only a few ERs موجود فيها. فنستخدم حنا اللي هو colorimetric Untitled CO2 زي المربع نشبك على ال end of the ET tube ويتغير لونه من purple to yellow when the patient has CO2 in their system. عندكم اي سؤال؟
اي يا دكتور عندي سؤال بخصوص الكونشس سيديشن اللي هو كيتو بروبوفول، ايش الميزه حقه؟
كيتوفول ما في ميزه كثيره على الكيتوفول. الكيتوفول ناس كانوا يقولون انه الكتامين يرفع البلاد بريشر، البروبوفول ينزل البلاد بريشر، فنعطيهم كيتوفول ميكس. ما نستخدم كيتوفول، احنا نستخدم الكونشس سيديشن مو بالانتبيشن. والحين الناس حتى يعني ستاديز لقت انه ما في فرق بينهم، فبعض الناس يستخدمون كيتوفول بعضهم ما يستخدمونه. بس ما نستخدم كيتوفول في الانتوبيشن، يا بروبوفول يا كتامين. يو كان بس ما له ادفانتج انك تستخدم كيتوفول. اي سؤال ثاني؟
شكرا لك يا دكتور على حسن التوضيح.
The movement of the tongue is done with the doctor's hand or what؟ لا بالبليد. لما تدخل البليد، انت شفت لما دخلت البليد دخله في اليمين، نفس البليد هذا فيه زي مصمم ديزاين انه يمسك التانج، فيمسك التانج ويدف التانج لللفت. انت تدخل البليد في اليمين ثم تلف توديه لليسار. اي سؤال ثاني؟ السي او 2 ديتكتور هذا بعض الماشينز عندنا في الطوارئ وفي الاي سي يو ولا الاو ار الديتكت السي او 2. فانت لما تحط once you intubate a patient بعد شبكته يطلع لك زي الويف. شفتوا الويف كيف كان الاصفر هذاك؟ هذا بين لك انه في سي او 2 قاعد يتحرك، انه السي او 2 ديتكتور يشوف سي او 2 يروح ويجي. هذا معناته انه التوب حقك في اللنجز، انه في الايرواي. لو ما كان في سي او 2 يطلع ويدخل يتحرك معناته انت في ستمك، لانه ستمك ما فيه. اي سؤال ثاني؟